Welcome, everybody, to a very special Tuesday VMR. I believe it's the 1,001th episode, so that's a major milestone. Yesterday was number 1,000 in VMR episodes. So I just want to congratulate everybody for making this a very proficient platform, a very successful platform. And I guess we have to. Do we start recording as well? Yep. Have to make sure. Okay. And I also want to announce that we have a very special day today. We have Amanda who's going to be co-discussing, and it's a happy birthday Amanda day today. So I want everybody to unmute your mic and just shout out happy birthday Amanda. Here we go. 1, 2, 3.
Happy birthday,
Amanda. All right. And yeah, go ahead, Amanda.
Hello, guys. So today is the first time I will discuss with Ravi, and it's a super special day because it's my birthday, and I am so excited to do this as a birthday gift, and hope you will enjoy. We have a case from Hashma, and do you want to introduce yourself?
Hello, everybody. I'm Reshma. I just graduated med school 8 months back. I did a rotation with Dr. Kunkan. I'm his student, and I've been with the CPS for good couple of months now, 3 to 4 months now, and I've been enjoying every single VMR here. And now, currently, I'm in the Bay Area doing research. And yeah, I have a case today to share with all of you.
Awesome. Should we get started with the chief complaint and deploy the whiteboard?
Yes. So this case has 6 aliquots in the final diagnosis. So aliquot 1 is the chief complaint. An 18-year-old male is brought by his parents with the chief complaints of persistent cough and cough with exercise for 3 to 4 weeks.
Okay. So I want to start thinking about the age of the patient. It's a young person, so cough makes me thinking about some infection, and I want to know about associated symptoms, and if there is something that trigger is this cough, or if have fever or nausea, vomiting, because I think when young people with this chief complaint infection, I think the first hypothesis, but they think other cause make the persistence cough, like some infectious disease and like HIV or other sexual cause. So I want to know about the associated symptoms and about the progress of this cough.
Amanda, that's such a great starting point. I just love your mental model for this, not to get too heavily invested with this complaint at the point, but trying to find co-identifying features, or maybe asking symptom-related your complaints. So asking if there are any provocative associations, if there's been any therapeutics that the patient has maybe used to improve this cough. But cough can be very non-specific, as we've seen from many VMRs. So we know we're somewhere in the vicinity of the respiratory system. And could it be the respiratory system, or could it be the nervous system? Because the nervous system, the vagal nerve, does track along various different areas, and cough could be a reflex from maybe irritation of the GI, from the respiratory passage, from the C fibers. You can name any part of the lung and the upper respiratory tract system, but there are some inflammatory conditions that we sort of think about, and Jas actually put them in the chat. So you have to think about in medicine, is there maybe something like a medicine causing it, namely ACE inhibitors? We always ask in the clinic if somebody has been on that. Then you also have to ask about reflux. You have to ask about exercise-induced asthma. You have to think about what was GERD. I think there's another new name for it, but it's sort of escaping me. But these are sort of some things you have to ask about. But I'm going to be kind of frugal at this point and not get too heavily invested in this complaint. But I'm going to see what else accompanies this. So we go back to Rishma for the next aliquot.
Yes. So the history of presenting illness. His symptoms started 3 to 4 weeks back, and he has been having the sensation of something being stuck to his throat. He feels like he's bringing up something, but the cough is non-productive, and he does not cough up mucus. 4 weeks back, his 2.5-year-old sister had an upper respiratory tract infection. He says he's pretty sure he has the same kind of URI, as she once coughed while sitting on his lap. Subsequently, he had 3 days of sore throat, but no fever or rhinorrhea. The sore throat resolved, but he continues to have a cough. 2 COVID tests were done after this event, and it came out negative. 1 week back, he was prescribed albuterol and fluticasone by his PCP, who suspected bronchospasm secondary to asthma or allergies as the cause, but he says they have not been helping. His cough is most significant when he lies supine, and his face turns red. He recently tried to bench press upon lying down. He started having a coughing fit and became short of breath. The cough does not wake him up at night, as he always sleeps on his side. There's a little more to this aliquot. 3 months ago, he had symptoms of excessive fatigue on waking up in the morning that lasted for more than 2 months. During his dental visit, his orthodontist suspected a narrowed airway on examination and ordered a polysomnogram. The PSG results were indicative of mild sleep apnea. Currently, the patient denies fever, but over the past few nights, he has been sweating. He has been having a decreased appetite without any difficulty in swallowing. His weight shows a 6 to 7 pound weight loss compared to the one 3 months back.
Very interesting. What do you think? What thoughts are crossing your mind, Amanda? We're sort of building a narrative here. A lot of information has been given, a lot of sort of preliminary investigations. How would you integrate that into your initial assessment of this complaint?
So it's a subacute case. Okay, so 4 weeks. So the acute case is like some abrupt infections. I don't think anymore, but lung infection or upper airway, I think can be like fungus or some virus and bacterial, but like a sequel. And other thing that I'm thinking is about the progress of this cough and makes me worries. And I think the obstructive cause like asthma or obstructive chronic pulmonary disease and maybe can representation this case of for this patient. You understand me?
Yeah, absolutely. It's interesting what the way I kind of spinning this case. It's going to be different to everybody that's in this room here. But yeah, infection, I agree. Kind of at this point, if I have to sort of start thinking, I mean, if I try to clarify this presentation, infection, this is sort of like how long was it again, Rishma? How long was the cough it started for?
It started 4 weeks back.
So 4 weeks. So into the sort of subacute category. Chronic would be more than 8 weeks. So we're not quite there yet. So with subacute, there are a couple of, if I remember, a couple of like infections like Bordetella pertussis has a certain feature with that whooping kind of cough. And usually the vignette will be somebody who works amongst children. And why do I know that? Because it's one of the board review questions that I usually review. So for cough, I think what's interesting here with the first visit to the clinic and the prescribing of inhalers, that's usually what's recommended. So when you have an initial investigation for this stepwise approach is usually recommended for what's called upper airway cough syndrome. So that's the variant I was trying to remember for GERD. So the initial evaluation would be to give some inhalers and sit back and hopefully see if things work out. But apparently it's not. And then what's interesting, this dental visit has shown a sort of preliminary investigation here that there's some narrowing airways. So now we're sort of moving into another domain of an anatomical issue. So a narrowed airway, you have to sort of tease out what kind of conditions can cause that. Is this something? This is a young patient. This is akin to Sunday's case where you have a young patient. Could it be something that the person is doing? So some social behavior related issue. Is it something related to maybe poor genetics, environment? And it could be also, you could also put in the infection, inflammation, and so on. But the young patients can manifest with certain number of things, namely genetic associated issues. But I'm kind of interested to see what more we can find. But now with this narrowed airway, I would anticipate in the exam, what would a narrowed airway show you on an exam? Some sort of stridor or some sort of turbulence in the examination. I'll be kind of amazed if there's no sort of lung sounds that would permeate down or resonate down to the bases. So we'll see what you do give us with the examination. Back to you, Reshma.
Yes. I'm going to go with the past medical history now. He was diagnosed with varicocele in 2019. No history of allergies or no surgical history. Social history, he's living with his mom and stepdad. Parents are married. He does not smoke or drink. Parents don't smoke or drink as well. He's not engaged in any sexual activity. He plays basketball, gets fatigued easily. And this was like recently. And his family history, developmental history, he was born at term, normal birth weight, vaccination complete. Childhood was unremarkable, no significant diseases, no family history of genetic conditions. Travel history, he was born outside the US, but we couldn't find where exactly, but he moved to the US when he was 6 years old. No recent travel history, but he has a history of exposure to tuberculosis from his family friend in 2018. Medication history, he is on albuterol and fluticasone, an inhalational spacing device from the last visit.
What do you think, Amanda?
So I think helps me about the exposure of tuberculosis, because I don't know if tuberculosis can be a manifestation a long time, like years, but it's a thought. And I actually, with this aliquot, I just not thinking much about pulmonary causes, but hematologic causes, like lymphoma that I saw, because patients of this age, it's very common. So I think with the physical exam and the hematologic and maybe an X-ray of the chest can help me. But here I think in this part, the exposed to TB, it's one thing that worries me.
Yeah, it's kind of interesting now. TB sort of come into the picture. There's also this part of the HPI where somebody, I think a family member, was also sick recently. So does that have any bearing on this case? Difficult to also say, but I really am intrigued in the physical exam. I think that will at least give us some signal to follow. Right now, there is a multiverse of different possible conditions that we can attribute to that. But I'm really interested, like, what is the lung exam? What is the upper airway exam? I mean, you could just run the gamut of different conditions from the upper airway, like people have so eloquently mentioned in the chat, from something in the nasal pharyngeal passage to epiglottitis to tonsillitis you may have in a young person. So any sort of narrowing, although we haven't had a formal examination of the airway, we just have some hearsay from a dentist that there's something brewing there. And I think somebody also mentioned something about inflammatory conditions. So what could sort of bubble under the mucosal surface? So a number of different cells. Maybe they could be leukemic cells. Maybe they could be eosinophils. Somebody mentioned eosinophilic esophagitis. So a number of cells could also congregate and cause some fibrosis or stricture there. Then people have also mentioned webs and all sorts of other things. So I think, again, we're kind of going to be frugal because, again, I don't have anything to really lay my head on in regards to what could be causing this process, but still very intriguing case. And I'm looking again, is this a systemic process or are we still in the vicinity of the airway or upper airway? So we'll see what Reshma tells us with the examination.
Yes, I'm moving to the vitals. His blood pressure is 115/67. Pulse is 102. Temperature 97.7 Fahrenheit. Respiratory rate is 16. And saturation 100% in room air. His measurements, height is at 74th percentile, weight 64th percentile, BMI 42nd percentile. And physical examination, his appearance and head and neck examination is unremarkable. His respiratory examination shows normal respiratory effort, no increased work of breathing when sitting upright, significantly diminished breath sounds on the right posterior lung fields. Breath sounds are clear in all other lung fields. No wheezes or crackles appreciated. Brassy coughs are appreciated when the patient is asked to lie supine. Face and upper body become red when patient lies supine. Coarse breath sounds with forced expiration. Cardiovascular system, normal S1, S2, no murmur, rubs. Abdomen and extremities and skin and neurological examination are unremarkable.
Wow, the game is afoot. What do you think, Amanda? There's a number of different things that we can really grab hold on to and maybe use it to get us to what's going on here. So do you wanna take this, Aliquot?
Yes, just let me know. The 97 Fahrenheit is not fever, okay? It's okay, it's normal. Okay, so I think I will continue with my blood disease because patients with this chief complaint in the normal pulmonary exam, I think I will not thinking about pulmonary GERD cause, and I will thinking about maybe neuro cause and hematologic cause. I think mostly in young people. So I think this is my thought. There is a tachycardia. Maybe he's anemic and have a tachycardia because of this. But I want to see the labs now.
Yeah, what I think as far as what do you think of this, the lung findings, Amanda? How would you interpret this? This is very intriguing to me, and I think it just kind of teasing that out for a second. I think it will pay dividends, I think. And then the second thing is this lying down effect. What do you think about that?
1 second, because I don't know what is the niche. Lower. So maybe the missions are right postural lung files, but with no, it's like with or calculus. I don't know how to say this in English, but here hematology, like blood in the lung, can be the diminution on the lung. You understand me? I don't know if I.
Oh, you're saying
Hemothorax.
hemothorax, yeah.
Pneumothorax can cause diminished lung fields. You understand?
Yeah, absolutely, absolutely. So we're thinking your approach to this is thinking of something that will take up the lung field. So blood could take it up, fluid could take it up, pus could take it up. For instance, pneumonia. So there's diminished lung sounds in that right lower lobe. So we have to think about maybe an infiltrate. Maybe there could be water. There could be blood in there, or could there be a pleural effusion as well? But then what Rishma also mentioned, this lying down effect caused this redness of the face. Is that right? What we call plethora. So facial plethora. So we have to start thinking this congregation of whatever is in the lung, or is it an isolated? Is it a synchronous effect, or is it two totally different things? And while the patient's lying down, there's compression of a vessel causing this plethoric sort of a manifestation in the face. So I think this calls for at least some imaging, but thinking about, somebody mentioned a mass could be at play here. So could there be a mass in the lung and a mass that could be compressing the superior vena cava? Other things that you look for this with superior vena cava syndrome would be at least engorgement of the vessels as well. And maybe one of the arms could be edematous, which we don't see here. So these are a few things that are coming to mind. And I think this does warrant at least a CT scan with contrast to see what's going on. As far as the examination in the lung, you can use other maneuvers such as percussion. Is the percussion note dull? If it's dull, that could be a pleural effusion. And you can even map out with percussion how far up with diaphragmatic excursion you have. If the note is sort of dull, but then you also have egophony, this could be akin to like a amplifier. So sounds would permeate through this infiltrate, and you get an increase in whispered pectrility, in egophony, and so on. And also, you may also have an increase in lung sounds as well. So you also, when you auscultate, think about if there's crackles, if there's rhonchi, if there's rales as well. So that way you can discern what may be brewing in the lung. But I think definitely it will be helpful to get some imaging to see what's brewing in that area. Any other thoughts, Amanda, before we go back to Reshma?
No, I just have a doubt about this part. To when patient is asked to lie supine, flushing of the face, their arms and expiratory round, can guide us to think about pneumonia. It's common or no?
Pneumonia causing this? So we're trying to relate pneumonia with an infection to this lying down, unless the patient has, I mean, the opposite of flushing would be maybe cyanosis if the patient is severely hypoxemic, which we're not getting here. So, but plethora would be kind of interesting, unless you have, say, polycythemia. This patient may have a plethoric face, but it would be, I guess, constant. It wouldn't be altered with lying down or sitting up. But maybe having a renal cell carcinoma, unlikely with the lung having polycythemia, unless you have secondary polycythemia from, say, a condition of COPD or being in a high altitude place or something like that. But yeah, the pneumonia, maybe there are two distinct entities that are happening at the same time. So we're really trying to force these two conditions together, but maybe they're two distinct entities. We've been like on VMR, we've been like sort of sidelined by two different processes on occasion, and we're because we're trying to unify these processes and forcing this diagnosis, there might be two simultaneous events occurring. Back to you, Rishma.
Yeah, so I'm going to eloquent 5, the investigations. His WBC is 5, hemoglobin is 12.9, hematocrit is 38.8, platelet is 179, MCV is 89. His sodium is 139, potassium 4.3, chloride 104, BUN 10, creatinine 0.8, calcium 9.4, glucose 9.2, bilirubin 0.4, AST, ALT with the normal limits, alk phos 304, albumin 4.7.
What do you think, Amanda? Did this move the needle for us, or are we still stagnated, not really moving anywhere?
The exam, then general, it's normal, but this phosphatase, alkaline phosphatase is high, so makes me think about the liver. So there is a problem in the liver, in the function of the liver, but the bilirubin, it's normal, makes me doubt. I don't know if I I know how to think with these labs. I think the imaging it helped me more.
I absolutely agree. Yeah, this really doesn't do anything for us. Maybe it does at this point with generating a number of hypotheses, maybe related to the anatomy of the lung, maybe that right lower lobe, maybe also that could be moving and compressing the superior vena cava, causing this flushing kind of phenomenon. And at this point, I think what will help us to at least verify, or we've refined a few of these hypotheses, but now to really verify this hypotheses, I think imaging will help us. We were kind of hoping that the labs may actually give us some signal, but we really don't get much here. But the imaging, definitely I would order. At least I would go straight for a CT with contrast, at least chest and then abdomen, pelvis, and then in one go take a look to see what exactly is going on. And the exam definitely did help us in sort of generating hypothesis and getting us to the vicinity of where this problem may lie. But very interesting case. I think this is definitely an anatomical issue. As far as malignancies, I'm seeing some people mentioning in the chat, yeah, yes, this is a young patient. We talked about bad genetics and maybe something like somebody's mentioning seminomas and so on, something metastasizing a mass to the lung. Difficult to say unless we didn't have a genital examination. Is that right, Reshma? Any masses in the testes?
It's normal.
Normal. Okay.
Yeah. So
the exam has no signal for any sort of a malignancy externally, but we'll have to see internally. And then what Amanda so eloquently mentioned about TB infections still come into play. What if there is some lymphadenopathy within the chest or a large mass in the chest that could be due to maybe an infection like that? So any other thoughts, Amanda, before we go back to Reshma?
No, I just want to see the imaging in thinking about serologists, about hepatitis B, C, and HIV, CMV. I think it's important here.
Oh, those are some great thoughts, especially if there's lymphadenopathy. I think ruling out, and if there's also maybe hepatosplenomegaly, although the exam didn't yield that, but even if there's mild, we sometimes don't do a top-notch job with physical exam, and we may not even decipher some enlargement of the organs. But yeah, definitely those conditions would be relevant if we do see those findings on an imaging study. Back to you, Reshma.
Yeah. So tuberculosis quantiferon test was done, came out negative. Spirometry with phenol was done, and the pre and post bronchodilator was suggestive of restriction by non-obstructive effect. There was no improvement with bronchodilator. The next one is imaging. If you want to go into imaging, or do you want to discuss this?
Amanda, what do you think about the spirometry?
I want you tell me because I don't know how to
Oh,
analyze spirometry.
that's
I
absolutely fine. Yeah. Was there any, do we have the actual spirometry? What kind of flow volume curve do you have for that?
Yeah, so FVC was 69%, FEV1 was 65%, FEV1 by FVC was 80%.
Oh, so those are all below 80, so they're all very low, and it's specifying the flow volume curve may have been very small in diameter, suggesting what you have here is a restrictive pattern. So there appears to be something going on in the lung restrictively. So I wonder with imaging, do we see a signal for maybe some sort of lung fibrosis that's occurring? This is interesting. I would have to go back and see if there is a upper airway obstruction. Obstruction could have a abnormal sort of flow volume curve, which would be more like oval shaped in that case. So with this restrictive, it's not the typical kind of upper airway obstruction that you would get with a flow volume curve. So I'm kind of interested now. There seems to be, we definitely know there's something in the lung that's going on. With all the different spirometry values being very low, that does raise some concern. However, the patient is respiring 100% on room air. This is only a matter of time. I think it's a progressive condition, and at some point later on, patient may manifest with hypoxemia. So very interesting to see what's going in the lung and also within the vessels. So definitely back to the CT with intravenous contrast.
Yes, so we had an X-ray done, and the X-ray shows a large anterior mediastinal mass extending to the right and left of midline. The mass measures 14.3 centimeter in the medial diameter, occupies retrosternal window extending to trachea and compressing anterior trachea above carina. And no calcification seen within the mass. Small bilateral pleural effusions noted, no supraclavicular or axillary soft tissue abnormality appreciated. Spleen is not enlarged. CT was done. CT confirms the X-ray findings and also shows that the mass encases the ascending aortic arch, encases and markedly narrows the left brachiocephalic vein and causes mass effect on the mainstem bronchi and right pulmonary artery.
Whoa, that's incredibly complex. Just trying to decipher the anatomy. But Amanda, what do you think? Now we are right. We're in that vicinity of the upper airway. It was the upper airway all along. What would you do next to move this case along?
I'm just thinking about this mess in the mediastinal mass because we have like the 4 T's of like hypothesis. It is cerebral lymphoma, tumoma, teratoma, and thyroid. So I think I don't know how to think one this disease. I think maybe other exams can give us the final diagnosis. But here, I what I have probably to say it's about the 4 T's, and what I know about the mediastinal mass is that.
Absolutely superb walkthrough of the anterior mediastinal mass. Using that masses, using that mnemonic. And I think out of these, what would you worry about more, Amanda? Which ones, a couple of them may not be relevant and maybe less likely, but at this age range, which ones would you really think would be causing this condition?
Actually, Ravi, I saw in the past a patient with a persistent cough with lymphoma. So young people with these symptoms and the chief complaint, I don't know if it's because I saw a case or if because I need to think, but I think cerebral lymphoma, it's my first hypothesis here.
Absolutely, I really like that. So if we had to kind of line up which ones are more likely, I think the lymphoma there, but that we have an 18-year-old, and I think the chat has probably put this comment or suggestion quite on fire, in that we have to worry about at least a teratoma or some other germ cell tumor. So that I am very intrigued if that this is at play. And if you look back at the HPI, what really stood out also, what can be non-specific, this patient has been very fatigued, although we're not seeing the usual accompanying weight loss that we usually do have with maybe something like this with the malignancy, but we do have this fatigue. Weight loss of 6 pounds. And then if you also similarly think about B symptoms, also some people have been putting that in the chat. The B symptoms may align with what you're thinking. Lymphoma may come as well. But I think some of these B symptoms could also come from a germ tumor as well. The others with a thyroid goiter, neoplasm, less likely. If you have a hyperfunctioning toxic goiter, I'd look for some sort of signal of hyperthyroidism in this patient, which we're not seeing. Other thing is then you have thoracic aortic aneurysm, usually again epidemiologically, maybe later at a later age due to atherosclerosis. With a young patient, less likely. So thymic neoplasm, possibly in this age range as well. What can be associated with a thymoma could be red cell aplasia, could, or hematological associations can be associated. Immunological associations can also be associated with this as well. But I think with Amanda, we've come to like at least one or two potential diagnoses that could be causing this. So I think what would be the next step, Amanda? What would you like to do?
I don't know, but I don't know if the CT resolves the case or if we need a MRI or maybe a bronchoscopy. I don't know if helps.
Oh yeah. Actually, that's a good way. We're thinking about biopsies, but a endobronchial ultrasound guided biopsy could potentially, because it is encasing the airway, it's compressing the anterior trachea. So this could be done by a laryngoscope. It could be done, it depends how far. You'd have to take a look at the imaging to see where could you deploy your bronchoscope, and then be able to take a biopsy through the wall of the trachea. Or could this be done externally by interventional radiology? So there's certain ways of getting a biopsy here, but this would require at least somebody reviewing the images to see what would be the best approach. So back to you, Reshma.
Yes, unfortunately, I don't have the images. I couldn't access them, but I will go ahead and reveal the final diagnosis. So his hospital course, he was admitted to the ICU, even though he was in a stable condition. Given the large mass effect on the heart, trachea, and bronchi, he was closely monitored for the risk of cardiorespiratory decompensation. An IR core biopsy of the mass in the lymph node was done and sent for pathological examination. Pathology showed T-cell lymphoblastic leukemia.
Wow. Amanda, what do you think?
Unbelievable. Oh my God. Always see the blood. Pathologic case, Ravi. Beautiful. So interesting. I never saw a case with this diagnosis, and it's very interesting because of the symptomatologies and about the imaging, and can be a lot of hypotheses. And I want to learn more about the final diagnosis, and I think I learned a lot. My hands is with pain because I super right during the session, but incredible.
Yeah, I was baffled by the size of the tumor. When I was reading the case, I was totally baffled. It says 14.3 centimeter in the chest. Oh my gosh! And also the CBC being normal was taken. I was taken by surprise, being with the diagnosis of a lymphoma, with the CBC and WBC being absolutely normal.
Yeah, that's what's interesting here, because early on we did sort of think about the bad genetics. So in a young person, when looking at this journey backwards, this cough definitely we were attributing it not to upper airway cough syndrome, GERD, asthma. So this is not your usual walk in the park of common garden variety cough. So it's attributed to something in a young person. And then you have the weight loss and night sweat. So, okay, B symptoms, Amanda had mentioned, this is very intriguing. Could this be lymphoma, TB, and so on? And then I think the exam was really where we wanted to really see what or how this was affecting this patient. And definitely there was a lot of signal and less noise in the examination. So we knew, okay, this is the area, but then what could compress on the vessels and cause this sort of a plethoric phase. So definitely we were thinking some sort of a mass, and within this mass, what's causing this? T cell, as far as I know, T cell lymphoblastic leukemia is very aggressive. So it just suddenly developed out of nowhere and just caused this mass. And it happens very, very quickly before the patient would have maybe a manifestation or maybe some sort of indication within the CBC. So I think for a lot of the audience here, the CBC didn't help prop up that suggestion. So I think that's where we kind of have to read and learn. But this is a very fast-moving, fast-growing tumor, and that's where we kind of like not thinking about it. So very intriguing case, and I'm very happy to see that this diagnosis was made and not this patient wasn't sent back and thought not to have a very serious disease. Now, how is this patient doing, Reshma?
He's actually coming on. He's still following up. He's doing good. He's on chemotherapy right now. And also one of the important point that I learned from this case was all patients who are diagnosed with TAL should undergo lumbar puncture before starting chemotherapy to rule out any CNS involvement even before starting the chemotherapy. That was interesting because when the first dose of therapeutics are started, it has to be started with the intrathecal therapeutics if there's CNS involvement.
Awesome. Thank you very much for bringing such an intriguing case, and thank you, Amanda, for co-discussing, and well done. Very difficult case, and happy birthday again. So I hope you enjoy in the energy of this case, and I hope this definitely was a great day to celebrate your birthday here with us today. I think Ibrahim has the teaching points. If you could take it away.
Yeah, sure. So great case and great discussion. Thank you all so much. So this patient, we had started with the history of cough, and when evaluating someone with a cough, you need to consider their age, whether the cough is productive versus non-productive, any associated symptoms such as fever, or nausea, or vomiting that could clue you into infection. You also need to think about triggers, progression, and analgesics or response to analgesics. And then in evaluating the differential diagnosis for cough, you have to think about the most common causes. So you have to start by evaluating for asthma, GERD, or postnasal drip. And then also don't forget the masses, as well as respiratory involvements, as well as neural involvement, as well as inflammatory conditions that can result in cough. And the differential diagnosis can be pretty much wide. So it can include upper respiratory tract infections, sequelae of infection, epiglottitis, tonsillitis, asthma, as we've mentioned. And then if it's subacute, you have to think about pertussis, think about TB. You can also think about extrinsic compression, just like in our case today. And those can include eosinophilic esophagitis, cancer, or esophageal webs. And then for such a young patient, you particularly have to think about behavioral, environmental, and genetic causes. And then also, if you suspect a patient with upper airway cough syndrome presenting to your office, you have to give them first inhaler trial, and then you follow up and see the response to that inhaler. And then if there is airway compromise throughout the history that you're getting from the patient, or you're suspecting airway compromise, you can look for Strider on examination. And then this patient also had facial plethora, and that was when they would lie supine. If a patient is presenting with such a case, you need to think about pulmonary versus extrinsic etiologies. The pulmonary etiologies can include blood, fluid, pus, or mass in the lung itself. And for extrinsic causes, you mainly think about masses. If you have a patient who's presenting with persistent cough with unremarkable locks, you need to go for imaging. And then if there is a restrictive pattern on pulmonary function test, you have to think about pulmonary fibrosis versus extrinsic causes. The extrinsic causes are mainly neuromuscular disorders versus mouse effects. And then if a patient ends up having a mediastinal mass on CT, you have to think about teratoma, thymoma, cerebral lymphoma, thyroid, and thoracic neurogenic tumors. And particularly, you have to think about teratomas if they're young, and you have to think about thymomas if there are hematological or immunological associations. And then also, I think Ravi mentioned the thoracic aortic aneurysms that can also present with cough. And then finally, if you have a patient who's again presenting with a mediastinal mass on CT, you have to confirm their final diagnosis with a biopsy.
Thank you, Ibrahim. Such wonderful teaching points. Appreciate for doing this. Thank you, everybody, for coming on. I definitely have some great reading for today. So quite a puzzling case. And again, I appreciate Reshma for organizing this and for everybody helping with Reshma to bring this case to us. So take care, everybody. Have a great rest of Tuesday. See you.
Thank you. Bye.
Thank you.